Okay, so hello everybody. Welcome to our second lecture in a six-part series on audiology. I'm sure people will continue to filter in, and we'll go ahead and get started since we have three speakers tonight. We have three graduate students from the University of Melbourne who are in their final year of their master's in audiology, who are going to give a talk on how to interpret an audiogram. There will be a short kind of quiz where everyone can be involved. We'll open it up to questions. So there will be more discussion this time than we were able to do last time. So there will be time at the end, but without further ado, I'd love to introduce Nada Al-Ashi, Hamed Sarwari, and Eris Pei, who will be giving our lecture tonight. So thank you very much for being here and for joining. And for all of our participants, if you would be so kind as to let us know in the chat where you're from, what institution or city that you're in, what country you're in, so that we can kind of share that as a group at the end as well. Thank you.
Thank you, Leah. I'm just going to share my screen. Hopefully everyone can see that okay. All right, so today we're going to be talking about how to interpret an audiogram. So I'll be doing the sort of first section, and then I've also got Aris and Hamid that are going to cover a few more of the topics. So before we test anyone's hearing, we do otoscopy. And what that is just using a light like the one that you guys can see in the picture there. And that's just to check on the ear canal. So checking if there's any collapsing canals, if there's any earwax that's occluding or blocking that canal as well, because that can affect our hearing too. When we're looking into the ear, we're also looking for any signs of any ear infections or any evidence that the person's had any surgery or trauma. So sometimes we can tell this by a scar, for example, on the tympanic membrane. All right, and in terms of the equipment that we use when we're testing someone's hearing, typically headphones are used, which is the one in the middle. And then red is for the right ear, blue is for the left ear. And that's the same for the insert earphones, which are the ones on the left of the screen there. The insert earphones are the same, so red for right and blue for left. And they're typically used when we're dealing with collapsed canals or standing waves. There's also a bone conductor that we may use during some testing. And just as the image is there, the bone conductor sits behind the ear on that mastoid bone, and a bone conductor is used to determine if the hearing loss is originating from the middle ear or if it's more to do with the inner ear. All right, so the frequencies we typically test when we're testing someone's hearing differ depending on the type of transducer that we're using. So for insert earphones and headphones, we typically test 250, 500, 1000, 2000, 3000, 4000, 6000, and 8000 hertz. Whereas the bone conductor, we only test 500, 1000, 2000, and 4000. At the University of Melbourne, we also test 3000 hertz for the bone conductor. Now, how do we hear? So sound travels as vibrations of air, and this vibration travels through the outer ear, through the ear canal, and it vibrates the tympanic membrane or the eardrum. And behind the eardrum sits, like you guys can see in this little photo here, it's those three little red bones that are there. And they're called the ossicles. So it'll vibrate those ossicles, and they'll then pass pressure waves in. Ossicles are the ones that are just sitting in that middle ear, and they pass the sound over to the inner ear or the cochlea. So what's a threshold? So thresholds are what we measure when we're testing someone's hearing. And it's the lowest sound or lowest volume that the sound a patient is able to hear at the frequency that we're testing. To ensure that we do have the true threshold, they need to get 2 out of 3 responses when the sound is presented on ascent. So we don't just test the threshold or the frequency once and they respond and we take that as their threshold. It has to be multiple times just so that we ensure it is their genuine response. So air conduction, as we discussed earlier, is what we are testing when we're using headphones or insert earphones. So sound travels through the outer ear again and into the middle ear. So we're past the eardrum and where those 3 little ossicles or the little bones are that sit behind there. And then from there, it goes to the cochlea, which is in the inner ear. All right, and so for air conduction testing, it relies on those 3 areas of the ear. So the outer, the middle, and the inner ear. So here's an audiogram just on the right of the screen. So the red circles are representing the right ear, while the blue crosses are representing the left ear. Now, with air conduction testing, whenever a frequency is equal to or better than 15 dBHL, so on the y-axis of the audiogram, we can see what dB we're at. So that's the volume that we're testing. And at the top, just across, is the frequency we're testing. So if any of the frequencies we're testing has a volume equal to or less than 15 dB, we consider that normal and our testing is complete. So those are the air conduction results for that one. All right, so for bone conduction testing, and that's that little sort of headband that you wear that sits behind the ear on the little mastoid bone, that actually vibrates the skull mechanically and bypasses the outer and middle ear. So that's directly sending the signal that we're presenting to that inner ear. All right, and for bone conduction testing, what we typically do is when the air conduction thresholds are 20 dB or worse, we would then go on to do bone conduction testing to see what type of hearing loss this person may have. So for example, in this photo here of the audiogram, if we look at 1 kilohertz, their hearing is at 15 dB, which we consider normal. So for 1 kilohertz, we wouldn't be doing any bone conduction testing. However, if you look at 2K, where the person's hearing is at 20 dB, because that's outside our normal range, we would then conduct bone conduction testing on this individual at 2K. All right, so just again, so to read an audiogram, you've got the volume just on that y-axis, and that's measured in dBHL. And then across the top, you can see the frequencies. So they're measured in hertz. Again, red is for right, and that's represented by the circle, and the X is for the left ear, and that is also blue. An easy way to remember is R and R are together, so right and red. All right, and this is what bone conduction testing looks like on an audiogram. So it looks like kind of a little bracket. So again, right is for red and blue is for left. And these are all unmasked thresholds that we're looking at, but we'll get to masking a bit later on. These are a few more symbols that you might come across when you're looking at an audiogram. So if we look at the blue icons at 60 dB, that is left ear air conduction results, but these ones are masked. And Aris will talk to you guys about what masking is shortly. And then if we look at 30 dB, that is left ear bone conduction that has been masked. So looks a little bit different to the unmasked thresholds, which are sitting at about 5 dB. If you look at the little legend that I've created just on the side as well, you can see the circle that's completely colored in as red is the right ear masked air conduction. And then the right ear masked bone conduction is quite similar to the left ear. It's just red and pointing in the opposite direction as well. All right, you might also come across these symbols when you're looking at an audiogram, and this is when someone doesn't respond to any presentations we've done. So it could indicate a dead ear if there's just completely no response across the audiogram, and that's just represented by either the right or the left ear showing a little arrow pointing down, so suggesting their hearing is potentially worse than this, or there's just no response. And I'll pass it over to Aris now, and she'll go through the next few slides with you guys.
Thank you, Nada. Yep. So in this photo here, we see the different levels of hearing loss. And for thresholds between -10 to 15 decibels, we would consider it as normal hearing. And between 20 to 40, there is a mild hearing loss. Between 45 to 65, there is a moderate hearing loss, and between 70 to 90, it is considered as a severe hearing loss. And those that are beyond 90 are considered as a profound hearing loss. Yep, so as Nada was mentioning about the audiogram previously, when we describe an audiogram, we talk about which ear the hearing loss is affecting, the configuration shape, which I will show you some examples in a bit, and the hearing loss, which I will also the type of hearing loss, which I will also discuss next. The frequencies that are affected and the degree of the hearing loss, which is determined by the air conduction thresholds. Yep, now let's go through some of the examples on how to describe the audiogram. So in this audiogram, we can see that there is a hearing loss in both the left and the right ear from 1 kilohertz onwards. It is a sloping hearing loss affecting the middle to high frequencies, and it is mild to profound hearing loss. So we would describe this audiogram as a mild sloping to severe hearing loss in the mid to high frequencies bilaterally. And in this audiogram, we see that the right ear is within the normal range, and there is a hearing loss in the left ear because the thresholds are at 45 decibels. So it is a moderate flat hearing loss across all frequencies. So we would describe this audiogram as normal hearing in the right ear and a flat moderate hearing loss across all frequencies in the left ear. This is also known as a unilateral hearing loss, as there is only a hearing loss in one ear. Yep, so there are mainly three types of hearing loss, and I'm going to talk you through them. First, we have the conductive hearing loss, is when there is a problem in the outer and or the middle ear. Some examples of conductive hearing loss are middle ear effusion, which means that there is fluid built up in the space behind the eardrum. And another example is wax plug, where there is a significant amount of earwax being built up. So to be able to identify a conductive hearing loss from the audiogram, we will see that the bone conduction thresholds are in the normal range, which is less than or equal to 15 decibels. And we would see a hearing loss in the air conduction thresholds that are greater than 15 decibels. Yep, and sensory neural hearing loss is when there is a problem in the cochlear in the inner ear or beyond. An example of a sensory neural hearing loss is age-related hearing loss, also known as presbycusis. From the audiogram, we identify a sensory neural hearing loss when both the air conduction and bone conduction thresholds are outside the normal range. And both the air conduction and bone conduction values have a difference of less than 15 decibels. So we can see an example on the right here, which shows the sensory neural hearing loss because both air conduction and bone conduction thresholds are outside normal range and have a difference of less than 15. Yep, the third type of hearing loss is mixed hearing loss. For mixed hearing loss, there is a problem in both the outer and middle ear and in the cochlear or beyond. An example of a mixed hearing loss is when there is an age-related hearing loss with a wax plug. In this audiogram on the right, we see a mixed hearing loss when both the air conduction and bone conduction thresholds are outside the normal range, but the air conduction thresholds are more than 10 decibels worse than the bone conduction. Yep, so just now Nada was talking about masking. I'm going to share more about it with you now. Sometimes when we have 1 year with normal hearing and the other year with a hearing loss, or even 1 year that's better than the other, the better year may be the one that's responding, even though we are presenting the tone to the poorer year. So as to ensure that the poorer year is the one that is responding reliably, we play a different sound to the better year to distract it, which is what masking is. And we do this to ensure that the good year is not the one that is helping out to respond to the tone. Yep. Now, Hamid will talk to you about.
Okay, thank you, Aris. So now I'm going to go through a few things that you guys should be watching out for and looking out for when looking at an audiogram. So firstly, I'll go through a significant sensorineural asymmetry. So you might be wondering what that is. So this is a sensorineural difference or a bone conduction difference between the ears at up to 3 adjacent octave frequencies that totals at least 30 dB. So by adjacent frequencies, I mean frequencies that are next to each other. So for example, 1000, 2000, they're next to each other. And then by octave frequencies, I mean frequencies that are double. So for example, we've got here 500, 1000, 2000, and 4000. These are all octaves. And we've also got 3000 and 6000. Now you might be wondering why we need to look out for this or how is this significant? So a significant sensorineural asymmetry may indicate a retrocochlear pathology. So a pathology that is occurring higher up above the cochlea. And this may warrant further investigation. But in next week's symposium, they'll be discussing this and every other pathology in more detail. So a significant sensorineural asymmetry can come in different shapes and sizes and can look like anything. So in the next few slides, I'm going to go through a few examples of what it may look like on the audiogram. So what we can have is we can have an asymmetry of 30 dB at just one frequency. So on the example here, we have a bone conduction difference or a sensorineural asymmetry of 30 dB at 3 kilohertz. We can also have an asymmetry of 15 dB or more at 2 adjacent octave frequencies. So in the example here, both at 1 kilohertz and at 2 kilohertz, there is a 15 dB bone conduction difference with the left ear being poorer. So when we add these two adjacent octave frequencies up, there is a 30 dB difference. Now in the example here, we can have an asymmetry of 10 dB or more at 3 adjacent octave frequencies. So in the example here, at 1 kilohertz, there's a 10 dB bone conduction difference. At 2 kilohertz, we have a 15 dB bone conduction difference. And at 4 kilohertz, we have another 10 dB bone conduction difference. So this is a significant asymmetry. Now you might be wondering why I didn't consider 3 kilohertz in this. And the reason is because we look at adjacent and octave frequencies. So 1, 2, and 4 kilohertz are adjacent, and they are octaves because you have 1000, 2000, and 4000, which are all doubling. So now I'm going to go through another thing that we should always be looking for. So this is a significant change in hearing. And for example, you have a patient whose hearing test you did last year, and they're back again for an annual hearing test. The one thing we want to look for when we get their new result is to check, has there been a change? And if there has been, how much? And whether this is significant or not. So when I say a significant change in hearing, this is defined as 15 dB or more change in a threshold within 12 months or a year. So in the audiogram example here, at 2 kilohertz, 3 and 4 kilohertz, at both ears, there has been a drop of 15 dB or more over 12 months. So with this, we would flag it as a significant drop in hearing in both ears. Now I'm going to go through tympanometry. So tympanometry is another essential test that we always do in clinic. And this just adds further to our audiometric results. So tympanometry is a measurement of middle ear compliance or health. Now, when I say middle ear, this is what Nada described before. So the place I've circled in red between the eardrum and the inner ear. So where we have our three bones and just that empty cavity or space. So tympanometry checks how well our tympanic membrane or our eardrum is moving, and if there is any blockage within this middle ear space. And we use tympanometry results together with our other audiological tests to come to a good conclusion. So what do tympanometry results look like? So over here we have a graph, which is a classic tympanogram, or what a tympanometer, the machine, would show us when we do tympanometry. So there's a few values here that I'll go through. So the first thing the tympanogram will show us is the middle ear compliance. Now, the middle ear compliance is basically a measurement of eardrum vibration or eardrum movement, which I have circled up here. So in this example, it's 1.5. Peak pressure, and this is a measurement of the pressure at which the eardrum compliance or movement is maximal. So this can vary anywhere between -400 to +200 decapascals. And the peak pressure is where we have the peak or the top of the little graph or the little mountain. So again, if we look down the peak pressure here, it is approximately -25, which we have written here as well. The next thing that a tympanometry result will give us is equivalent volume. So this is the physical ear canal volume. So I've got normative values here. So for adults, it is anywhere between 0.6 to 2.0, and for children, 0.2 to 1.0. But I just want to let you know that these are a very rough guide, and there are different ways to looking at equivalent volume, including comparing to the other normal ear. But I'm going to go through a few examples later just to make sure that makes sense. So with tympanometry, we can get different types of results. So they give us tympanograms. We can have a type A tympanogram, type B, and a type C. And now I'm just going to go through what those mean and what they look like. So first of all, a type A tympanogram. This is where our middle ear compliance is anywhere between 0.3 to 1.6. So 0.3 to 1.6 here on the graph. Our peak pressure, we have a sharp peak as shown on the graph here, and it is greater or equal to -100 DAPA. So over here. Now, what a type A tympanogram means, it is consistent with normal middle ear compliance and an air-filled middle ear cavity. So the middle ear that I showed you before, we want this to always be air-filled. So with the type A, it shows that it is air-filled and middle ear compliance is normal. It's telling us that the eardrum is intact. There's no perforation, no hole, and there's no fluid in the middle ear. And we've just got our tympanogram here, which just shows a type A. So middle ear compliance here is 0.9, which is normal. And our peak pressure is around 0, and that is normal as well. So type A tympanogram. Now with the type A tympanogram, we also have two subtypes. So a type AD and an S, and I'm just going to go through what those mean. So firstly, a type AD or deep tympanogram. This is where we have increased middle ear compliance. So our middle ear compliance value is greater than 1.6. And this means that there is decreased or reduced stiffness, or we have an overly mobile tympanic membrane. And in terms of peak pressure, it is the same as a type A. So it's a sharp peak and it's greater or equal to -100. So because we have increased middle ear compliance, it will have a very tall peak. And as we can see here on the tympanogram, it's a very tall peak, and the middle ear compliance is 1.7, which is a type AD. A type AD is consistent with increased middle ear compliance and still an air-filled middle ear cavity. So a type AS or a shallow tympanogram, this is where we have reduced middle ear compliance. So middle ear compliance reading of less than 0.3. And this tells us that there is increased stiffness, or we have a very stiff tympanic membrane that is vibrating or moving a lot less than what we see in a type A. Our peak pressure again is the same as a type A. So it's you have your one peak and it is greater or equal to -100. But because our compliance is so small, it's going to look a lot shorter and fatter. So that's a good way to tell that it's an AS. And a type AS is consistent with reduced middle ear compliance and again, an air-filled middle ear cavity. So now we're going to move on to a type C tympanogram. Now, the easiest way to determine you have a type C tympanogram is by looking at the peak pressure. So a type C tympanogram is where our peak pressure is less than -100. So your peak is more on the left side of the graph. Now, what this means is that in that middle ear space, there is negative pressure. So if we see the tympanogram here, our peak pressure is at -200. This is below. So this is a type C tympanogram, and it is consistent with negative pressure in the middle ear. Now we have type B tympanograms. So these look a little bit different, and they do have two subtypes. So a B low volume and a B high volume. So with a type P tympanogram, there is no middle ear compliance reading. So no movement of the tympanic membrane is observed or measured by the machine. In terms of the peak pressure, the mountain, we actually don't see that either. It is usually a flat or a very rounded response, and there's no real sharp peak visible. So you might be thinking, how can you tell, the difference between a B low and a B high? So with type B tympanogram, the equivalent volume is a key indicator, and we use that all the time. And this can help us indicate whether the tympanic membrane is intact, whether there is fluid behind the eardrum, whether there is a perforation, so a hole within the eardrum, or if there is a patent ventilation tube. So a ventilation tube is like a little rubber with a hole in the middle, which they put in the eardrum, and this just allows air to bypass and go through the middle ear and for any fluid to come out. But next week in the Pathologies lecture, they will go through that with you. So first I'll go through a type B low volume. So as I said before, if we look at the tympanogram here, the peak pressure, we can't really see any tall mountain. There is no visible peak, and it's just a flat line. In terms of equivalent volume, with a type B low volume, our equivalent volume would be low. So this can be volume less than 0.3, but as I told you before, the volumes were a very rough guide. So a good way to look at this is if the volume of one ear is significantly lower compared to the other ear or the normal ear. So for example, if we have the left ear tympanogram, this is a type A, and my volume is, we would say 1.0. My right ear would come as a type B, and the volume is 0.1. So the volume in my right ear is significantly lower than my left ear, which is a type A normal volume. So that indicates that it's a B low volume. If we look at the graph too, it would be a flat line like this. So a type B low volume is consistent with intact tympanic membrane. So there's no perforation, no hole in the eardrum. And it's also consistent with a middle ear pathology. So something going on in the middle ear causing blockage, which can be middle ear effusion or the fluid buildup, which Nada and Aris discussed before. But we can also get a type B low volume if there is a lot of wax just occluding and blocking the eardrum. Because what would happen is with the tympanometry, as you saw in the first picture that I showed you, there's a little tip that we face towards the eardrum. If there's a lot of occluding wax, we can have that tip facing that, and it's just going to be a very low volume that it's going to measure. So the next subtype we have is a type B high volume. So again, in terms of peak pressure, no visible peak. It's just flat or a rounded line. You don't get your nice sharp mountain. In terms of equivalent volume, it will be a high volume. So this can be a volume of greater than 2.0, or it can be a volume significantly higher compared to the other ear or the normal ear. Now, this is consistent with a non-intact or a perforated tympanic membrane. And it can also be consistent with a patent ventilation tube. Now, how could you tell the difference whether you have a perforation, so a hole in the eardrum, or whether there is that ventilation tube, that little rubber tube that helps air and fluid to go through the middle and the outer ear? So we would use otoscopy, which Nada showed you at the first slide. where we'll look inside the ear and see if we can see any visible ventilation tube. If not, then it would be a perforation. So now it's time for the quiz. We've got a few questions for you guys, and you guys will be answering it through the poll. Just have fun with it and see, you know, what you guys get, and hopefully, yeah, we'll go from there. So RS, you can take over.
Yep, thank you, Ahmed. Okay, so the first question. Yeah, the first question is, what does a bone conductor measure? For option A, we have health of the middle ear. For option B, middle ear hearing levels. Option C, the cochlear or the inner ear hearing levels. And option D, the outer ear hearing levels. Yep, so now you can choose your answer on the poll over here.
I'm not sure if the polling is working.
Yeah, I was going to say there's a poll that should have popped up for everyone. Otherwise, guys, feel free to drop your answer in the chat box as well.
Yep.
Yeah, that might be easier.
Mm-hmm. Thank you.
Let's see.
Okay.
Chowie, are we able to get the, oh, there we go. Yeah. At least one response and a question about tympanograms.
Yep, so for this question, the answer is the bone conductor measures the cochlear and the inner ear hearing levels because as Nada mentioned just now, the bone conductor vibrates the skull mechanically and present the sound signal through vibration passing through the outer and the middle ear. Yep, the next question, please. So the next question is, what degree of hearing loss is this? A is moderate hearing loss, B, severe hearing loss, C, mild hearing loss, and D, profound hearing loss. I'll give you a hint and a reminder for this question. For mild hearing loss is between 20 to 40 decibels. For moderate hearing loss is between 45 to 65 decibels. Severe hearing loss between 70 to 90, and profound hearing loss is 95 and beyond. Feel free to put your answers on the chat. Yeah, so for this question, the answer is moderate hearing loss because the thresholds are between 40 and 60, so it is a moderate hearing loss. The next question is to describe this audiogram. Option A is normal hearing bilaterally, meaning both ears. Option B is severe sensory neural hearing loss. Option C is high frequency mixed hearing loss bilaterally. And D is mild low frequency conductive hearing loss bilaterally. Yep, looks like everyone got it right. The answer for this is mild low frequency conductive hearing loss because in the low frequencies there is a mild hearing loss since the bone conductor bone conduction values are in the normal range, it is a conductive hearing loss. And the next question is, what type of tympanogram is this? Option A, type B, option B, type A, option C, type C, and option D, type E. Yep, it is a type A tympanogram because the peak is more than or equal to -100 and the mid-ear compliance is between 0.3 to 1.6. And for our last question, also what type of tympanogram is this? Option A is type A, B is type B, C is type C, and D is type E. Yeah, so C is correct because the peak pressure is less than -100. There is a negative pressure in the middle ear. So we have come to the end of our presentation. Feel free to ask any questions if you have. Thank you.
Thank you so much, all three of you, for that really wonderful overview. We're going to open it up to questions now and have everybody be able to ask live questions. I'd ask that once we do that, if you could raise a hand, then we'll call on you individually if anybody has questions. And I noticed a couple come into the chat, one from Jeffrey. When would you get a tympanogram showing no reflex was one question that was asked. Who wants to answer that? And then Chowie, we can open it up and make it a gallery view for everybody.
All right, so for that reflex question, I think it's going to be something that one of the other topics we'll talk about, but there are a few examples of where you can get a tympanogram and not get reflexes. One of them would be a conductive hearing loss. So conductive hearing losses can get in the way of being able to record a reflex. So that would be one example. There's a few other examples. So if there's a very severe or profound sensory neural hearing loss, that can affect it as well. But you can still get a type A tympanogram, for example, even with a very severe sensory neural hearing loss.
But usually, so when you have a conductive hearing loss or a difference between the bone and the air, so what is a reflex? Do you want to go into that? Yeah. So Chris has asked us to first explain what a reflex is, just to make sure that everyone is on the same path. So the question was, when would you, get a tympanogram with no reflex? So a reflex, do you want to describe that and I'll go through those?
Yep, so a reflex is the change in emittance of the ear. So trying to think of another way to explain it. Chris, did you want to jump in?
Sure. So hi everyone, I'm Chris. I'm one of the lecturers. I'm going to put my video on. So a reflex is something that we measure. There's a thing called an acoustic reflex, I think that you were talking about here, which is something that we can do as well as tympanometry, which is measuring a little reflex that happens in the middle ear in response to loud sound. It's like a protective mechanism. All right, so we didn't go into a lot of detail around that here. It's not something that's done routinely these days. It used to be, but not anymore. I think the important thing is around how we measure well the eardrum is actually moving itself. So that's what tympanometry is doing. It's measuring to see how well the eardrum is moving. If there's fluid behind the eardrum, something stopping the eardrum from moving, there may be negative pressure, as these guys talked about, which is an indication that there might be eustachian tube dysfunction. So if someone's got a cold or if someone's got a lot of sinus problems, they often have problems with their eustachian tube opening and closing. And as a result of that, you'll probably see negative pressure. So you'll see that type C where you're getting the peak in the negatives. And then you've got your type A's, which is where you've got your eardrum moving normally. As we, I don't know if you guys wanted to explain what happens with tympanometry, how it actually works. I don't know if that would be helpful for people. Just really briefly, like in a paragraph.
Yeah. So I guess tympanometry, you're presenting or you're changing the pressure within the ear canal and seeing how the eardrum responds to the change in that pressure.
Yeah, that's right. So it's like you've got this probe that you put into the ear. It's sending a tone in, and depending on how much of that tone gets reflected back off the eardrum, we know how well the eardrum's moving, right? So we're changing the pressure in the ear canal, and if we puff a bit of air inside the ear canal, we see the eardrum sort of get pushed in. And then when we suck a bit of air out of the ear canal, we see the eardrum move and it actually gets sucked out. And if there's normal air pressure behind the eardrum, we see the eardrum the most compliant when it's around 0 pressure on the outside and also on the inside. So that's a good indication of normal middle ear pressure. All right, so that's just in a nutshell how that works. So maybe some other questions there.
Yeah, there's Dr. Buname from Tanzania is asking about differences in ranges of normal hearing. He references the WHO and the scale that you had, and perhaps if you guys have any comments on, on different ranges that exist globally, because I think this is something that may come up when speaking to international audiences like this, that the ranges may differ.
Yeah, so the ranges that we used were the ones that the clinic for the University of Melbourne is currently using. There is some variation across, I guess, different countries and things like that. And there's also within audiology, so if you test the same person across different days, there'll be variation in their hearing as well. So especially like that 5 dB above or under difference, because the closer you get to someone's threshold, they may hear it sometimes, but may not. And because we take it the 2 out of 3 responses, it can sometimes be that they did respond at a quieter level or they did respond, louder. And it's just that happened to be the one that they responded to on that day. So I think, yeah, there is a bit of variation. And I think different countries maybe consider a hearing loss to be like a higher level of dB, or as long as someone is able to hear at an okay level to be able to communicate, it's, fine.
Yeah, I think we see, even within countries, it can be quite different levels. So some will take 20 as being within the normal range. I think at our university, we take 20 as being a hearing loss, but there are other clinics around that will say 20 is fine. In some countries, 25 dB would still be classified as normal. So I'm not sure if anybody else wants to comment within their country what's classified as normal. Have we got any other variations, even just on the call that we've got today? If anyone wants to put that in the chat.
You're also welcome to unmute yourselves and jump in. We've had up to 35 participants today, but yeah, feel free if you have live questions.
There are some cases where, for example, if one threshold is a bit higher or at 20, we still consider that essentially normal, but we wouldn't call it normal in our university clinic.
Yeah. Nada, I like how you commented about, how much it's really impacting somebody. And I think in a lot of the countries, where our participants are from, that's a very practical point where, if hearing aids are not available or otherwise, then the rationale for the threshold to be lower may be very reasonable.
And I think another thing to consider would be, like, for example, in our university clinic, the room is completely soundproof. So it is easier to hear those quieter sounds, whereas some clinics maybe don't have the opportunity to have something that's completely soundproof, and it would be quite difficult if there is other sounds sort of around to hear those really quiet ones, which might be why they're a bit more lenient on what normal is considered to be. That's a very good point.
Yeah, great point. And I think also we find the same thing when you're screening. And I think perhaps that this is something really crucial if you're going and doing school screenings, or if you're in a medical facility somewhere and you're screening, you don't want to take 20 dB as a hearing loss. You don't, even 25 sometimes, background noise can be 25 dB. And therefore you're going to pick up, nearly everyone's going to probably fail that. So you've got to sort of be mindful of the sound environment that you're actually testing in.
Yeah, that's absolutely true. So I work part-time at this private place where we do screening of patients. So we don't have a soundproof booth. So even though we put on the headphones, I've tried it myself, and you can hear some background noise. So we've actually changed our threshold just to match to see, because it will be unrealistic to expect someone to hear all the 15 dB tones without being in the sound treated room and hearing just all that background noise. So we've actually elevated ours to, as Chris said, around 25 as well, to 30.
That's great. We have another question from Kasuga from Uganda. Hello, could you please re-echo, I think this re-echo comments about octave frequencies and retrocochlear pathology on audiogram.
Go for that one.
So I'll start by discussing what we mean by a retrocochlear pathology. So a retrocochlear pathology is basically a pathology or something that is occurring past the cochlea. So in this lecture, we've talked to you about the outer ear, the middle ear, and the cochlea itself. So if there is a hearing loss within the cochlea, that's a sensorineural hearing loss. If there is something occurring past the cochlea within the auditory nerve, so that can be a acoustic neuroma, some form of tumor, anything else that's going on, that's what we would term as a retrocochlear pathology. And octave frequencies, so what we look for is that 30 dB difference at most at 3 adjacent octave frequencies. So by octaves, these are basically multiples or doubles of each other. So 500, 1000, 2000, 4000 are octave frequencies. If there's a difference at 3000, the octave frequency for 3000 would be 6000, not the one next to it. And would make sure that they're adjacent octave frequencies. So octave frequencies are next to each other. So 3000, the adjacent octave frequency to 3000 is 6000. Now, with our ears, they are both the same age. They age at the same time, and they're both exposed to the same noises. So usually when it comes to a sensory neural or a bone conduction or a cochlear loss, we expect it to be similar in both ears. So when there is that significant asymmetry, that big difference, we just want to investigate whether there might be something higher up causing this, such as a retrocochlear pathology in one ear. And that's why it warrants further investigation. And I'm sure next week in the pathologies presentation, they'll discuss what this further investigation entails and what we actually mean by that.
Stay tuned.
Any other questions?
I actually had one question. Nada, in your slides early on, you mentioned a standing wave as an example of,
Yep.
I forget, I think, I don't even remember what context it was in, but could you explain that?
Yeah. Okay, yeah. So a standing wave is pretty much, so sometimes when we test with headphones, the sound sort of goes in and then bounces back towards the headphone out of phase. And what that can do is actually cancel out the sound that we're presenting. And because of that, it might be, oh, this person looks like they have a hearing loss just at this one particular frequency. But you'll find that if you are getting that sort of issue, it could be just a matter of either repositioning the headphones or switching to those insert earphones, because they sit in to the ear canal a bit deeper, it kind of, you don't have to deal with that standing wave issue as much anymore. I think standing waves are typically more of an issue in the higher frequencies. Another option, if you're dealing with standing waves and don't have those insert earphones readily available, is to use a warble tone instead of a pure tone. Yeah, so that's just a few ways to combat that sort of issue.
And I had a question to you. You mentioned collapsing canals. People
Yeah.
may not have heard of that term before. What is a collapsing canal?
Okay, so a collapsing canal is pretty much, I'm just going to show you guys on Hamid if you turn around. So we basically check sort of pressing on the ear like this. And with some people, when you press on any outer region of their ear canal actually snaps shut. So what that means is with testing is if we put headphones on them and we're putting that pressure on the outer ear and their ear canal closes up, there's going to be a restriction of the sound that we're presenting there as well. And the insert earphones are the ones that can maybe hold the ear canal open for us while we're presenting the sound. And that's typically found in people with very like sort of floppy ears or bigger ears, and generally in like the older population as well.
And you might be thinking what the implications of a collapsing canal is. So pretend you've put headphones on, there is a collapsing canal. What you might see in the audiogram is actually a pseudo-conductive loss. So this is where it will show that if they don't have a conductive loss, it might show that there is, or one that is bigger, only because there is actually something covering the sound, so it's difficult for them to hear. They will have higher thresholds. Whereas then when we test with the bone conduction, they will come at their level. So the difference between the air and the bone will actually look a lot larger than what they might be. Kasuka, so you wrote that normal middle ear pressure, like you mentioned, is -400 to +200. Why is -100 in type C considered a negative middle ear pressure? Okay, so what I meant by that is that with tympanometry, it will show you the pressure reading will be from -400 to +200. So this is the pressure that the tympanometer will put through the ear, and at whatever point that the pressure within the ear canal and in the middle ear is equal, that's the point where the peak pressure will be. So what we define as normal middle ear pressure is when it's greater or equal to -100. So that's why if we have a peak pressure of less than -100, that's what we say is a type C, and that's because there is negative middle ear pressure there. And that's, because as Chris said, with the eustachian tube dysfunction, it's not opening or closing as well. So there's just a lack of air there. So you just have negative pressure in there.
Great questions.
Yep.
Anybody else? Again, feel free to just.
You're welcome.
Kasuka, are you an audiologist or ENT? Just out of curiosity. No pressure if you don't feel like sharing. I had asked earlier, but if everyone feels comfortable just sharing at least where they're from, I know a number of people on the call. We have people from Tanzania, Uganda, Cambodia, the US. There's a number of people here I don't know. So if you do feel like sharing where you're from before we sign off. We have a question about any known like scholarships. Do you, I guess to clarify, for programs that accept people from other countries, et cetera, if you guys have any knowledge about that. That is something that does get asked a lot. So whether today or otherwise, if ever there are resources like that, we can help message out to our listservs about that. So, but that is a question that we just got.
Yeah, it's a really good question, and there's a huge need for more courses in audiology, particularly in countries where there's such a huge need. And we know 80% of hearing loss is occurring in lower middle income countries, the global burden. So, increasingly a huge need for that. And we certainly at Melbourne, we do have a number of people coming from different countries. And I know there's some, I think in Africa, there may be some courses in Kenya, I believe. But in terms of scholarships, that's a different story. And I think that, there's absolutely a huge need for this. One thing that I think we're passionate about is just really looking at ways in which people can have access to resources, because there's a huge need for this, even just in basic screening, training, and treatment of sort of basic treatment of middle ear disease, primary care, these sort of things. There's a huge need for that. So slowly but surely, I think there's a gradual increase in access to these sort of resources, which is good and much needed.
One thing I will plug that's coming down the pipeline, both Chris and Dr. Buname's team in Tanzania are involved with, we're developing some smartphone training modules in audiology. So these will be accessible, and we will definitely share these through the Mending Kids listserv and otherwise once we have them up and running, but they're still being developed. So it's not a full course, but it is a smartphone module where we can do some basic training, and people can learn more about how to do some audiograms and other things. So that will be coming down the pipeline, and stay tuned for that. Chris, I don't know if you have anything to add to that.
Yeah, no, it's been great to be a part of this, and we're currently sort of in that process of testing out the modules. So one on just audiometry, and the other one on tympanometry, and a few others that are coming. They're in the pipeline too. So it's great to be a part of it, and hopefully, you guys can experience that and have access to that as well.
We do have ways of testing very young children. It's not exactly the same as audiometry, and I think one of the later weeks they'll be going through this anyway, but for us to be able to get separate ear information, you're right, we do need a child to be able to follow instructions, and that typically is around the 3-year-old mark, where we would basically play a game with the child that teaches them to play with us every time they hear the sound. And yeah, so that's how we test them. We can test them using speakers, so just playing sound into the room and seeing if they, turn towards the reward that we give them when they hear the sound. And we can typically do that at quite a young age, so a few months old. But again, that only gives us information on how both of their ears are working together, as opposed to each ear separately. So they may have a hearing loss in just one ear, but they're responding with their better ear. So we won't be able to tell, unfortunately, the full sort of results until they are a bit older and we're able to get that separate ear information. So hopefully that helps.
At what age would you say you'd be testing pure tone audiometry, with the button pushing?
I recently have had an 8 and a 10-year-old, and I did not use the button on them. I got them to clap every time they heard the sound, because I feel like it's more fun for children. But depending on the child, like the 10-year-old was sort of getting bored of the claps, and I was like, oh, you've leveled up, here's a button, you're on level 2. And you just got to sort of keep them entertained, because with children, when they start to get bored, they're not going to keep, doing the tasks you need them to. So with children, a big part of it is that encouragement and ensuring that they're engaged in the task as well.
Yeah, that's good. I think typically sort of school age plus, so sort of around so 5, 6, 7 years old, you can start trying them with pure tone audiometry. But yeah, again, that issue is around concentration sometimes. keeping them engaged can be a challenge. But yeah, we will have a session on play audiometry as our final session. So yeah, stay tuned for that. That'll be really helpful, hopefully.
Great. Well, we're at the hour. Thank you all so much for joining. Just to get the times, we're going on East Africa time. I did notice some late joiners, but we're doing these at 7 a.m. and there's some time changes around the world happening right now. So we're just going to keep it at that time, 7 a.m. every other Friday, more or less. And if you're on our registration list, then you'll receive a reminder prior. So thank you so much to all of our speakers from the University of Melbourne and to all of you who joined the call today. We really appreciate your involvement. Yeah, we look forward to continuing this series on audiology in a couple weeks. So we'll see you then. Thank you.